All right, so we are back with another PCBH Corner, and we have a fantastic topic for us. We're going to be talking about penetration rates, which in layman's terms is just kind of talking about reach into the population. And we know one of the big reasons for integrating behavioral health into primary care is to be able to reach more people.
Absolutely.
And we know historically the low rates and percentages of people in the population who are able to be served if we do things only a traditional way. So I guess that's where I want to get started. Could you maybe explain some of these terms so far? We've already used penetration rates, unique patients, reach. What are we talking about here?
Yeah. In penetration rate, or I guess we're integration rate that we're talking about, like either one really. But the idea being is, as you were saying, what percent of people that come into the clinic over a given specified period of time have seen a BHC. And so the thing that's interesting is there's a lot of key things that we need to define before we
get there.
Right? So the first thing is, like, what is a unique patient? And I think you always give a good example of what a unique patient is. Do you want to go through that as far as, like, if you see Bob, Sally, and Tim?
If you see Bob, Sally, and Tim 3 times each, that's 9 visits. Well, your unique patients is 3.
So it's 3 individual people. How many individual people have you served
exactly
last year? Great. The other thing becomes, what does it mean to see the person or to have a visit with that person?
That's true.
You know, because the interesting thing is there's a lot of different ways that people could say, like, oh, I touched that person or whatever that might be. That could be doing a chart review. That could be just, consulting with the PCP. The way, and we're not saying we're right about this, but the way that we say that someone enters into this equation would be if we had a meaningful clinical encounter with that person. So what we define as a visit.
Exactly. Yeah. So if we have like a meet and greet situation or a situation where you stop and you give a handout, you don't even, like in the EHR, you would just save it as a message.
Right.
And then if you've done some type of meaningful clinical encounter, which has some level of assessment in it, some level of intervention, then that's when you document it into the HR. And we had run our numbers, and I think it was 98% of our visits.
Yeah, a little bit over 98%. Yeah.
Oh, right. Were billable visits. So they hit that threshold of that 15 minutes and 30 seconds to be billable. But at the same time, when go ahead.
Well, I was going to say that also goes for the PCP status. How do we know this person's coming into the clinic? The way that we define this is not necessarily the unique patients that are assigned to the clinic, but it's like how many of the unique patients assigned to a clinic has seen a PCP as well. So I think that's an interesting thing too, because you could take this, like our health system says we serve 30,000 patients, which is probably true that we have 30,000 unique individuals that are assigned to us. A little bit over 21,000 people actually make their way into the doors and see a PCP. So that's the number that we're looking at.
And we're always talking about a 12-month snapshot.
Correct.
So that's another key factor when we start throwing around these terms. So basically we're looking at who has had a medical visit in the last 12 months. And like we said, if I can't remember who we said now, but Billy, Tom, and Susie, if they all came in for a medical visit and they all had 3 or 4 visits with a medical provider, it'd still just be the 3 of them. They're the unique patient. And so those are the folks that get put into the denominator.
Boom.
For, hey, they had a medical visit. Now, out of those 3, how many of them had a meaningful clinical encounter with the BHC?
Boom. Well said. And I think the other thing to really pause on is that 12-month snapshot. Now, again, it's an arbitrary time frame. It's a good one because a lot of reports get thrown out based on years. And it's an interesting thing. Like if you do it too short, like if you do it like a month or 2 months, really that's not doing anything other than just saying how many visits that you had in the moment. Now, you might have seen some of them people back within those times, but really giving yourself enough time to actually address, what's a good time period that we're going to assess? And for us, it's a year. For us, it's 12 months that we look at. Now, we do have previous data that would look at like 5 or 6 years, which is actually really interesting.
It was really cool to see.
Yeah, we might actually talk about that. But for us, the main data metric point is a year that we're looking at. What percent of people that have seen a primary care provider in the past year has also seen a BHC.
Exactly.
Yeah. And why that number is important is that when we look at the general population, we've talked about this routinely, and when reports get put out, it's anywhere from 8 to 13% of the population, the United States adult population, will see a mental health provider in a given year. So this goes back to what you were saying about access being a big thing, and that equation about impact, that we might have effective stuff, but we're not really reaching too many people.
Right.
And that's what that penetration rate and that integration rate really starts to get at, that reach that we want to look at.
Yeah, and if you're looking at impact, we have to do the reach times effectiveness.
Yes.
So I know we've talked about that before, but it's simple, but it's profound.
It is. It is.
You know? So it's like, yeah, you're doing great work, but you're not seeing anybody, or everybody, it's a touch point. So it's like, well, I reviewed their chart.
Correct.
I talked to a PCP. I gave them my card. Again, I'm not saying that those inherently are bad. I'm just saying that those don't really tell us a lot about what's happening. When we start getting into those meaningful clinical encounters, especially given the current state, I was going to say in the United States, but it's really around the world. One of the biggest concerns that folks have with mental health is access. And so we spend all of this time, does PCBH work for outcomes? Does it do this? Does it do that? When really we know primary care already works. And if we're able to show our reach, then you're solving a problem. And if you look at why primary care was put into place, it was supposed to be the safety net. It was supposed to be the first place that you go when something comes up in your community.
It's going to reach a lot of people.
Exactly. And you go back to those 4 C's of your first contact, the continuity of care, the comprehensive aspects of care, and then coordination of care. It's that hub, it's that home.
Amen.
And so we get to be a part of that, and it's addressing that issue.
And I think the cool thing is too, is like, obviously the number in and of itself is a pretty almost in a vacuum, really great number that just shows, again, unique patients, and then penetration, the percent, the integration within the community. I think that in and of itself speaks for itself. And though, I would also say is that I think you can make the argument, now this would be an assumption, it would be derived, it's not necessary, we would have to look at this a little bit more, is that if you have a higher penetration rate, it's showing that there's uptaking that's going on by PCPs and by patients, right? Because if your penetration rate is low, you could probably look at that curiously. It's like, why is our penetration rate low? It could be because you don't have enough BHCs. It could be because PCPs aren't bought into the idea. It could be that patients are like, hey, we don't like this service. We've heard from other family members not to do this, and there's like stigma associated with it. When you start to see the penetration rate really go up, though, it could be a reflection of other values outside of just simply reach into the community. So I think that's a cool thing too.
Yeah, are you talking about then patient acceptability?
Correct.
Is that kind of the...
Exactly.
Yeah, and provider acceptability with the team-based, with the team-based care. Yeah, we're getting hit with allergies. Like everything is blooming.
It's fun times.
That's why we got the pink, spring.
So I think this also comes into this question about, and we get asked this a lot, it's like, hey, we like this idea of integration rate. We like this idea of a penetration rate and looking at that. It makes sense. It's a thing that reflects our values. What should it be? Right. And it goes back to almost kind of like what the values of how many, or the PCBH Corner that we did on how many visits should you have. And my thing is always going to be, it's like, I don't know, as much as you can.
Yeah, right? As much as you can.
Yeah. And it's interesting. So, at CHCW, we've seen this and we've tracked this metric since 2016, and we really have seen it just grow and grow and grow. And it's fun, if you're on social media, and whether it's Facebook or other avenues, that you get these memories that come up, and, we'll have a memory that Bridget and I will make a post, and it's like from 4 or 5 years ago, and it's like 18%,
Right.
Which that
was really good.
I think it is really good at our the mothership clinic at CWFM. That was at 18%. It's like, that's great that, almost 1 out of every 5 patients that are coming into that clinic is seeing a BHC. What we're at now, though, is that we're seeing is that throughout our entire organization, it's about, hitting that 1 out of every 4. It's about 25% of the entire organization.
Right.
At our mothership clinic, it's 30%. So we're getting to that 1 out of every 3. And then the most one that we're proud of, and I would say, like, this is just an incredible thing. It just shows the incredible work that our BHCs have done and the staff have done in our clinic that's set up to serve our kind of migrant farm working community that has a lot of monolingual Spanish speaking. They're at 37%, coming up on 4 out of every 10
Right.
that come in are seeing a BHC.
And I think a few things we have to note for our audience. This could only happen if you're continuously adding BHCs to the mix, because I mean, you should look at each individual BHC to kind of see where they at. Are they seeing the same patients over and over and over again? And from our math that we've done, it's about 2.5 visits that most BHCs have per patient.
Right.
So if we can do some simple math, if a BHC had, let's say, 1,000 visits, then
oh, you got it. Oh, no, 400. It would be 400 unique patients, most likely, right? Would that be right? Yeah, 400. Because 400 times 2.5 would be 1,000. We're gonna go with it. We're gonna keep that going. But the idea being, yeah, it would be 2.5. Let's do the math. Just do the math real quick. And as you're doing that math,
I thought I had the math, which is why
as soon as she started saying, let's do some basic math or simple math, I was like, oh, buddy, that's going to be...
400.
It's 400. That's right. That's right.
Exactly.
Yeah, it's 400.
Yeah, so if you had 1,000 visits...
You average 2.5 visits per patient. You had like 400 unique patients.
Exactly.
Yeah.
Exactly.
Exactly. And that's what we see within our team. And again, it does fluctuate. And I think it's a really good, I love how you're almost saying this is almost like a process measure as well, to give feedback to the team, that not only about the gestalt of what our reach is to the community, that giving the feedback to the BHCs, hey, other BHCs, or this is how many unique patients they're serving, they're in the same amount of clinical, they're having the same amount of visits that you are, but you're kind of significantly more or significantly less as far as unique patients go. What's going on there?
And what we find is that there tends to be, like you said, there tends to be a range amongst some folks. There's going to be some folks that tend to be a little bit more solution focused. There's going to be some folks that tend to have people come back a little bit more. As long as you're falling between, 2 and 3, somewhere in there, of visits per patient, you're probably going to be just fine. Because the other thing you have to take into account, in addition to BHC personal style, is the context of the setting.
Amen.
So if you're at a place that has maybe a lot more options and tons of resources, just in general, not that they're necessarily going to go specially mental health, but there's
options.
There's resources too.
Yeah.
Because some folks, when there's no resources, it's kind of like, they keep coming back to primary care.
Right.
Exactly. So if there's folks that are a little bit more rural, or there's less options just in general for things, you can kind of see that play out.
I think the other thing that this penetration rate really highlights, and I think it's an important one, I was just having a conversation with one of our BHCs about this, is that if we continue to make PCBH about a behavioral health intervention in healthcare, there is a finite ceiling that we will get to. And almost like there's a finite penetration rate that you're going to get. We've always said this, we're not big on diagnosing it's like a pathology, but if we just use that for the sake of the argument, about 20 to 30% of the United States population at a given time has a mental health related DSM-5 disorder. So you can almost make the argument that if you're hitting 20 to 30% penetration rate within your primary care, if it's a behavioral health intervention, you succeeded.
Yeah.
You're good, right? A really good way of saying it, like, you're good. You don't need to worry about seeing more. If it's a healthcare intervention, though, that's focused on helping people change behavior,
be the best version of themselves,
that's evident.
be healthier version, healthiest version.
Until you hit 100%, my mind would say, we got room to go. And I think that's a really interesting point about how the penetration rate can also maybe, not necessarily saying clearly, but maybe reflect, what is your PCBH program focusing on? Is it a behavioral health intervention, or is it a primary care healthcare intervention? Because if it's a primary care healthcare intervention, that ceiling is never there.
Right.
It's always going to be infinite.
Right. And so just to give some more numbers that just give you a little bit of an anchor, that in general, if across the population, in general, people are coming in for about 8% of the population is getting mental health. So generally, you're going to want to shoot for that.
Yes, that's a great point. That's a good floor.
Yeah. You're going to want to shoot for that. Now, of course, look at your resources, because if you only have one, And then there's a local
Great
agency that's seeing 8% and they have 20 people.
Great point.
If you have one and you're at 3%, that's actually probably pretty good.
That's actually a really good point. And we've heard of systems that like maybe they have like 30 to 40 PCPs and one BHC. It's like, yeah, we can't expect that one BHC to get 8% of the population. Really great point.
Right.
Yeah.
And so the idea would be to build up your team.
Yes.
To be able to say, okay, can we get 5%? All right. Can we get 8%? Once you get there, now you're looking for 12%. I know in Oregon, they had given incentives for organizations that were able to get to 5% and then to 12%. And then Kirk had in his earlier writings on lessons learned, he had basically said that, hey, a well-integrated place is shooting for 20%.
Yes.
And so as we've talked a lot about, we don't have, which is why, was it Jody Palaha and them had put out that call for, hey, like let's go over the recipe.
Yes.
Let's talk about the ingredients that what makes up PCBH, because we really don't know. The implementation science is still new on this, but we have to start somewhere.
Yes.
And so that 5%, that's where I would start if I was a brand new place. And then I would start trying to figure out how can I build my team to get to 8%? How do I get to 12%? And then reaching for that 20%, all the while, and then you'd have to have folks be there for at least a year, all the while monitoring, how many patient visits did you have?
Yes.
How many unique patients did you see? And just kind of see if you're hitting between that 2 and 3 zone. If you're over 3, nobody panic. It just might be an indicator that you're seeing the same patients back over and over again.
As we're having this conversation, as you were just describing that, I really do think, like, for us now that we've been doing this for 10 years, we've had this data point now for over 6 years, 8 years actually, if it's since 2016, is that it really now has become more of an outcome measure for us. At the beginning, though, I really do think it's a process measure. I really do think it's a reflection of, like, are we moving towards these things?
We do check that with our new BHCs.
Yes.
So when we're giving them that feedback of watching their visits per clinic steadily grow, their warm handoffs per clinic, I am keeping an eye on that unique patients.
Yes, and as you think about, and we've talked to some of our clinics about this, that as you add BHCs, say the penetration rate only goes up 1% or something, you're like, wait a minute, like, we're adding more BHCs, like, what's going on? That's another conversation to do. Are we just seeing, like you said, not only is the individual BHC, maybe is the entire team just like kind of seeing the same group of patients? Are we not branching out into these other groups? So it's a really neat measure, really great data point.
So I have a question for you on that, and I think this will help our audience. Yeah. In general, if somebody is in clinic, primarily that's their main function, let's just say about 80% of the time, which, some folks get admin time built into their day, some have it designated elsewhere, some people have some other duties. Let's just say they're 1.0 and they're patient-facing or maybe clinical-facing for 80%. What numbers are you looking for approximately?
Yeah, and I'll bump it down to 70% just because that's what it's the easiest one since we have some data about it. What we see for the people that are in clinic, about 70% of the time, we see the unique patient number being between 500 to 600 unique patients. And again, unique patients meaning they had a meaningful clinical encounter.
Was that high?
Oh yeah.
Oh my gosh.
Oh, yeah.
Because I know that there's
like Amelia, even Sarah, which is only 60%, is eclipsing that 500 mark. Yeah. So 500 to 600.
I know in some of the rural areas where, like we were saying, there's not as much resources in general, that folks have had a propensity to see people back a little bit more than what you might anticipate, just because of loneliness and like what we were talking about earlier.
And what's really great, one of those BHCs that is in the rural clinic during one of our group supervision, and they help lead this, they actually commented on that. Like, what, this is making me think about, like, it potentially not, it's such an interesting thing. Like, I know we always get like, oh, we feel bad if we have people back. It's like, right. As you've always said, I think you've always done a good job. It's not bad to have people come back. That is not a bad thing. Like, of course we want people to come back. It's more of like, are we actually reaching into these new groups? And they were thinking about that BHC. So from what we have seen within our system, if you're working about 70% clinical, about between 500 to 600 unique patients in a year.
And what were we at when we're working like 30-ish%?
You are at, Bridget works a little bit more clinic than I am. You are at 200, I actually know the specific number, it's 239. And then I'm at like 211.
Okay.
So for us working 30% of the time, that's what we're at right now.
Oh, wow.
Yeah.
That's exciting.
Again, it's an actually new data point that we're starting to pull out a little bit about unique patients per clinic. How many unique patients are you serving in clinic?
Yeah, because there was, in the awards show, we do at the end of the year, most people who watch our PCBH Corners, you've heard about the monthly awards show. Well, we do an annual one as well. Mm-hmm. And that's one of the awards is how many unique patients per clinic.
Correct.
And I think did I win that one? Or did
you tied with, I think it was Sarah. I think you and Sarah tied for that one. I was right behind you. That was one I'm not going to lie, I was really proud of that one. Correct.
Because that told me that with the time that I'm in clinic, I'm reaching as many different patients as I can, which, as we know, can be very challenging when you're not working a lot of clinics. And when you've been we've been serving patients, this is year number 10 for us. So people will often want to come back to see, you see enough patients are going to want to, see you and stuff. So it was good to see, hey, even though that's the case, I'm still not seeing the same patients.
That's the thing
over and over.
That's the thing I took away from it too, because as you said, there's some good and bad things about being in clinic more or being in clinic less. One of the downsides of being in clinic less is that you probably are, just because you have a limited amount of time, more likely seeing people that you've seen before, because they're going to fill up your schedule a little bit. And I agree, it was cool to see that, hey, even with you being in clinic, you're still seeing a decent amount of unique patients, whatever that means, that metric means. So,
and the other fun thing about this is that I had a few folks that showed up on my schedule that I hadn't seen in 2 years. And it was this really cool thing that, again, for many folks that are watching this, you might be in training. You might be a pre-doc. You might be a post-doc. And you don't even have that opportunity yet to work somewhere so long to where a unique patient becomes a new unique patient, because you saw them.
Seen them in a while.
Yeah, you saw them 5 years ago, and now they're back on your schedule.
Which goes back to, I think, maybe one of the coolest parts that we've been able. Now since we changed EHRs, we've lost some of the longitudinal data.
Yeah.
We're going to build that back up. But when we were able to pull the penetration rate since 2016, this would say we're in 2022, so it would be 6 years.
Yeah.
The coolest thing was be able to look at your own unique patients. We're talking thousands of patients, thousands of humans within our community. And it's almost like a cool thing to reflect to yourself. It's this is the amount of people that I've seen. This is the amount of people that I've served. It's a humbling almost experience. And almost a reminder of this is what primary care allows.
Let's tie a bow on some of this stuff.
Yeah.
So if you're brand new and you're starting out and you're just building your team, you're going to probably want to first get somebody to get you a report that pulls in the last 12 months how many medical patients have come in, and then out of those medical patients, how many of them have seen a BHC, so that would be the numerator, the denominator, how many medical patients, and just kind of see where you at baseline.
And can I even say to that, I would say outside, let me know how your mind says, what your says, outside of visits per day, which I think should be the first metric that every single PCBH program, if you're developing a report, should be visits per day. I would probably say even more than handoffs. I would say
I agree with you.
Unique patients. Because handoffs in and of themselves, I don't think mean much if you're not seeing a lot of unique patients.
Right,
yeah.
right.
Yeah.
Yeah, and so then you're going to put your first goal probably about 5%. Your second goal would be 8%, 12%, and then you're going to be aiming for 20. The science has not caught up on what exactly a good number is. We have, folks who are experts who had identified this 20% as being well integrated. And then the most basic way of looking at this is,
You got it. Keep it going.
All right.
Keep it going. You got it. Well, the one thing I could say, if you don't have it, if you have it, go ahead.
Here, pause it so that you
No, we're not pausing.
We're not putting that.
We're gonna keep going.
We are not putting.
We absolutely are. So what do we got? Gonna have to show some flexibility. I'll go. So the other thing is that you could use this as an outcome measure, but probably at the beginning though, it's going to be more, as you were saying, this is going to be more of a process measure, more of a reflection of just like setting goals, allowing things to move forward. And it's a cool metric that not only the metric itself could be a very useful thing, it also could reflect PCP uptaking it, acceptability, patients uptaking it.
Yeah, and so what I was going to try to say was aiming for about 500 for unique patients,
nice.
And not getting overly fixated on that 500 number and getting really disappointed, but just assessing it, just seeing where are you at, and then just asking yourself a lot of questions. So we talk about metrics a lot, about them being reflections of what we're doing. We want it to be a reflection, and we want to have parameters. And we're just asking ourselves questions because in PCBH, you never quite make it. You're in a constant state of flux, and it's a constant iterative process. And you could be doing this like you and I on year number 7. We were doing it for years, and then I noticed that my handoffs dipped.
Yep.
And then I just had to ask myself some questions. So I wasn't mean to myself and say, "Oh, I'm not getting my numbers." Blah blah blah. You just have to ask hey, am I not being as quick, or what exactly is going on? So I think teaching your team how to have that iterative process, to use the metrics to tell the story.
That was brilliant. We should almost do a PCBH corner on that you never make it in PCBH because that's finite.
Yeah.
It should always be infinite.
Yeah, and you get different problems the longer you're there.
Oh, we could write a book.
Problems is a strong word, but you get different challenges at each stage of your career as a BHC with regards to, in the beginning, you're getting so many handoffs, which is awesome. But then the longer you're there, how do you have follow-up patients and handoffs? And then once you've been there for years, then it's kind of like, how do you manage not having only the same patients and to where you're not really there for the team? So it's constant challenges.
Yeah, we were just talking about that as the group supervision. What happens when you're 9 months in, and then it's like, oh my gosh, I have all these people that are coming back that want to come back, and I still need to be available for handoffs.
Yeah.
You're absolutely right. Well, as always, let us know thoughts. Let us know how your clinic is utilizing the penetration or integration rate. Leave comments, send us emails, let us know. But awesome job. I really like this topic. It was really great. Thanks for stopping by.